And I am going to hand it over to our speaker for today, Dr. Ayse Kuspinar. Welcome, Dr. Kuspinar. Thank you for taking the time to speak with us today.
Thank you for inviting me and for the introduction, Amy. I'm excited to be here today and to talk about measuring quality of life for people with Parkinson's. So before we start, I just wanted to give a general overview, outline of how the next 40 minutes or so will be broken up. I'll just briefly start with an introduction, just briefly introducing myself in terms of just my training, my background, and in terms on this topic, measurement and quality of life research, and then we'll talk about patient-centered healthcare and quality of life. We will review current measures of quality of life in that are used in Parkinson's. And I will also then we'll transition into current work that we're doing, which is to develop a new measure or index of quality of life for Parkinson's. So we'll start. So I'm actually from Montreal, and my training or clinical training is in physiotherapy. I studied in the physiotherapy program from McGill in the School of Physical and Occupational Therapy in Montreal, and it was this that really I'm quite passionate about my profession and advancing it through evidence-based practice and research, and it was really this that drove me to pursue graduate studies at McGill in the School of Physical and Occupational Therapy with a focus on health outcomes research and developing new and better approaches to measuring outcomes that are important to patients with neurological conditions. And an important part of this was quality of life. And I developed actually a quality of life questionnaire for people with MS, multiple sclerosis. And at times I will refer to this questionnaire during the webinar today. Following this, I then did a postdoctoral fellowship at the University of Waterloo in the School of Public Health and Health Systems. And again, my focus was in health outcomes research, but more so in older adults or community dwelling older adults, so with a focus on a different population. And now I'm at McMaster University in the School of Rehabilitation Science as an assistant professor in the physiotherapy program. And my research program is about developing interventions and strategies to improve the quality of life of older adults and individuals with neurological conditions. And it's also about improving the way we measure outcomes in people with different conditions. And Parkinson's is an important part of my research. And by outcomes, I'm really interested in outcomes that matter to patients and that are meaningful to patients, like function, participation, and quality of life. And so today we will be talking about measuring this important outcome, quality of life, in people with Parkinson's. So when we discuss patient-centered healthcare systems, the main goal of this type of system is to improve patients' health and quality of life. It's important to incorporate the patient's voice and perspectives when we're evaluating interventions. And interventions can be drug treatments or rehabilitation type treatments. And the ultimate goal of our healthcare interventions is to improve the quality of life of our patients. Quality of life is defined by the World Health Organization as an individual's perception of their position in life in the context of the culture in which they live and in relation to their goals, expectations, standards, and concerns. Quality of life is defined by health-related factors such as physical function, psychological well-being, symptoms like pain, fatigue, and it's also defined by non-health related factors such as someone's job, housing, personal beliefs, schooling, or the neighborhood in which they live. And quality of life can mean different things to different people. So two individuals with the exact same health condition and health state can and will likely have very different quality of lives. And quality of life can be influenced by different factors. For one person, the most important factor influencing their quality of life might be their physical health, for example. For another individual, their quality of life might be influenced by their satisfaction with personal relationships and participation in social activities. So quality of life is a very personal construct, and it can only be measured by asking the individual or the patient themselves. Quality of life is a patient-perceived construct, also known as a patient-reported outcome, which is any report that comes directly from patients about how they function or feel in relation to a health condition and its therapy, without interpretation of the patient's responses by a clinician or anyone else. Patient-reported outcomes provide a unique perspective on medical or rehabilitative therapies. Some effects of a health condition or its therapy are only known to patients, and we can only capture the effects by asking patients themselves. It's important that we have properly developed and evaluated patient-reported outcome measures in order to be able to capture meaningful treatment benefits. Poorly developed measures can provide misleading conclusions and misinformation about a treatment. Okay, I'm not sure why the slide is like that, but what I will it wasn't like that when I sent it, but quality of life measures reflect the view of the person. So they can help us capture aspects of a person's life and health that we can't measure with a test or a device, but that we can only capture from the patient's perspective. They can help us evaluate the value of clinical care from the patient's perspective, and they can also help us evaluate the perceived value of a new treatment from the patient's perspective. The patients are the ones that are receiving treatments, and they're the ones that we need to ask about the values or benefits of these treatments. So how do we measure quality of life in Parkinson's? So let's look at some of these measures together. The most commonly used disease-specific quality of life measure in Parkinson's is the Parkinson's Disease Questionnaire 39, PDQ 39. And as the name implies, it has 39 questions, and we can go through a couple of them here. So, due to having Parkinson's disease, how often during the last month have you had difficulty doing the leisure activities which you would like to do? And you have 5 different response options. So we have never, occasionally, sometimes, often, and always or cannot do at all. And we have, so these are our 5 response levels. And then we have next question is, how often during the last month have you had difficulty looking after your home? Had difficulty carrying bags of shopping? Had difficulty walking half a mile? So there's some questions on walking. Had problems walking 100 yards? And then had problems getting around the house as you would like? And then we go on to, there's some questions on fine hand use or dexterity. Had difficulty, there was some of these questions before we get to that. Had difficulty getting around in public? Did you feel frightened or worried about falling over in public? So question on falling. Had difficulty washing yourself? Had difficulty dressing yourself? So some questions on self-care. And then there are some questions on here, fine hand use, like writing clearly, had problems writing clearly, or had difficulty cutting up your food. And then some questions on mood, felt depressed, felt isolated and lonely, felt angry or bitter. So, and it goes on, and there are 39 questions in total. So the PDQ 39, it evaluates how often people affected by Parkinson's experience difficulties across 8 dimensions of quality of life. So we have mobility, activities of daily living, emotional well-being, stigma, social support, cognition, communication, and bodily discomfort. And this measure can help researchers and healthcare professionals explore the wider impact of Parkinson's on a person's quality of life, and also detect any changes following treatment. Another commonly used measure in Parkinson's is the SF-36 health survey. So this is a generic patient-reported outcome measure, meaning it's not specific to Parkinson's. It was developed for use across different populations and conditions. So it has 36 questions that describe different aspects of health. So if we look, for example, the first question, in general, would you say your health is excellent, very good, good, fair, or poor? And then the second question, compared to 1 year ago, how would you rate your health in general now? Much better now than 1 year ago? Somewhat better now than 1 year ago? About the same, somewhat worse, or much worse? Or then there are questions on physical functioning. Does your health now limit you in these activities that you might do during a typical day? And if so, how much? So vigorous activities, moderate activities, lifting or carrying groceries, stairs is another question, being able to climb several flights of stairs, climb 1 flight of stairs, being able to walk different distances. And this question has 3 response options. Yes, limited a lot, yes, limited a little, or no, not limited at all. And it goes on, and then there's also questions on social activities and pain. So and in total, there are 36 questions. And these 36 questions are grouped into 8 dimensions. So we have physical functioning, role limitations due to physical problems, role limitations due to emotional problems, bodily pain, vitality, social functioning, mental health, and general health. And each of these dimensions are scored from 0 to 100, where higher scores mean better functioning or better health. So these measures assume that all of these dimensions are equally important. But the challenge with using the SF-36 as an endpoint in clinical trials is if a person improves in one of these subscales or dimension, for example, let's say physical functioning, but declines in another dimension, such as mental health, it's hard to know what the impact of this intervention was on the overall quality of life of a person. So overall, did this treatment have a positive effect or a negative effect on a person's health-related quality of life? And that's hard to tell. So measures like the SF36 and the PDQ-39 are profiles, so meaning that they give you many values. So they give you a score for each dimension of quality of life. So they give you a score for physical function, a score for bodily pain, a score for vitality, social functioning, etc. And the other type of measures that we have, quality of life measures, are called indices. So these measures give us one value or one score of quality of life. And so let's look at these next. So indices are also called preference-based measures. They're a type of quality of life measure that's derived from economic and psychometric traditions. And these measures are based on the central concept that individuals have quantifiable preferences or values for health outcomes. So these measures take into consideration the values that an individual attaches to each of the dimensions of quality of life. So some of the dimensions might have a higher value than other dimensions, and indices take this into account. And because they're able to quantify preferences or values for health outcomes, they're able to give us a score or value of overall quality of life. And this score usually goes from 0 to 1. So they're able to give us a single number for quality of life that's anchored from 0 to 1. 0 being worst and 1 being best. And being able to measure quality of life on a ruler-like scale from 0 to 1 is really important and useful because it can help us directly quantify from the patient's perspective the impact of a treatment on their quality of life and whether this treatment was beneficial or not. And another point is what's also useful about indices is that they can actually help inform decisions on the cost effectiveness of treatments, whether a treatment is better or superior to an existing one and at what cost. This is important for policymakers when allocating resources and making decisions about the implementation of treatments and programs. So indices are usually short. They usually have 5 to 8 questions. The EQ5D5L, as shown on the screen here, is an index and has been used in Parkinson's. It's one of the most commonly used indices in Parkinson's. And the EQ5D has 5 questions. So it has one question on mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. So 5 questions in total. And like the mobility question, for example, I have no problems in walking about. I have slight problems in walking about. I have moderate problems in walking about. I have severe problems in walking about, and I'm unable to walk about. And the respondent is asked to choose one option from these that describe their health today. Or, for example, the pain question. I have no pain or discomfort. I have slight pain or discomfort. I have moderate pain or discomfort, severe pain or discomfort, and extreme pain or discomfort. So we have 5 response options for each of these questions. So these measures were developed using general population values. So members of the general public were asked to value each of these dimensions, not patients. And the EQ5D is a generic measure, so meaning it wasn't developed specifically for people with Parkinson's. It was developed for use across many different conditions. And this way, it allows us to compare quality of life of people with Parkinson's with those with, for example, other neurological conditions like stroke, MS, ALS. So being able to compare the quality of life of people with Parkinson's with other populations is a really useful quality of these measures. But at the same time, the challenge is they might not perform so well in the context of a specific disease or health condition. So what we did was look at the performance of these measures in people with Parkinson's. And we wanted to know if these generic indices, like the EQ5D, capture the areas or dimensions of quality of life that are important to people with Parkinson's. And interestingly, what we found was that most of these measures didn't cover many of the dimensions or areas that were important. Most of these measures were missing more than half of the areas that were important to the quality of life of people with Parkinson's. Dimensions like dexterity, sleep, fatigue, cognition, tremors, speech, bowel and bladder were missing from these measures. And what this showed us is that there were problems with the content validity of these measures in Parkinson's. There was also a review published a couple of years ago on the performance of these measures in people with Parkinson's disease. And the authors found that these measures generally had good convergent validity. What this means is they were able to relate pretty well with other measures of quality of life. But there were issues with the sensitivity of these measures in capturing the benefits or impact of treatment on quality of life. So the sensitivity or ability of a measure to capture change is very important. And this is important when we want to make decisions on whether a treatment should be implemented in practice or not. So what all of this brings us to is that there's a gap that needs to be filled when measuring quality of life in people with Parkinson's. We need a measure that gives us one value or one score of quality of life that includes the dimensions that are important to people with Parkinson's, that is sensitive to change with treatment, and that is based on their preferences or values and not those of the general public. And so what I would like to do is co-produce with people with Parkinson's a new quality of life measure, a short index that measures the impact of Parkinson's from their perspective, that is comprised of the dimensions that matter to people with Parkinson's, and that is weighted by their preferences with respect to living a life that is valued. And what would be useful from a clinical context is a measure that's short, so minimizing respondent burden, that's easy to fill out, that targets the key domains that are important to people with Parkinson's, that incorporates their values in its scoring, and that will give us one single score of quality of life that is meaningful. And I would like to design this measure so that it's sensitive to change. This way, it can be used to monitor the quality of life of people with Parkinson's over time, and also tell us how they respond to treatment. The first step in this process is really, and what we will do is ask people with Parkinson's to identify the aspects of their life that are most affected by their Parkinson's. So the first question we will ask them is, what are the aspects of your life that are most affected by your Parkinson's? And this question is really key because it will shape how the rest of the measure will be. And the way that we will do this is we will ask people to identify up to 5 domains or areas of their life that are most affected by their Parkinson's, which is here. So first they'll identify the areas that are most affected by their Parkinson's. Then we will ask them to rate each of these areas on a scale from 0 to 10. So 0 being the worst and 10 being best. And then quantify the extent to which they wish to improve these areas using 12 imaginary tokens. So for example, a person might identify fatigue as a main area of concern, as we can see on the screen here. And then if we were, and they might rate that area on a scale from 0 to 10 as a 2 on 10. So where 0 is worst and 10 is best. So 2, quite on the lower end of the scale. And out of their 12 tokens, they want to allocate 8 tokens to this area. So quite a substantial amount of their tokens are will be allocated to this area. So meaning that this is an area that they would pay more to improve. And then another area might be walking, for example. And they might give this a 6 on 10. So a little bit higher, not as bad as fatigue. And they would allocate less tokens to this, 4 out of 12 tokens to this area. So this is really important because it will help us know what are the areas that we need to focus on and that we need to incorporate into our new tool. And once we have these domains or areas based on what people with Parkinson's tell us, then we will form a working group of researchers, clinicians, and people with Parkinson's who meet locally and over the internet, and to really develop the items. So we have the broad areas. Once we have those broad areas, then we will turn those into items. So develop items. And these items will be developed simultaneously in English and French, which will allow us to resolve any problematic wording and discrepancies between the language versions. And at this stage, we'll probably have about 3 to 5 questions per domain. So per area. So for example, we might have 3 to 5 different questions for physical function. We might have 3 to 5 different questions for cognition. And at this stage, we want a large pool of questions. So the working group will develop a large pool of questions to provide our sample of participants with the opportunity to review these items and rate their importance. So we will ask a sample of people with Parkinson's to complete the prototype questions that the working group developed, and also rate how important each question is on a 5-point Likert scale, from not important to extremely important. And this process will help us select the most relevant items or questions that we need to include in our index. So once we have that process, then we will do cognitive interviews with people with Parkinson's. And we will conduct a series of individual interviews using Skype, Zoom, phone, based on participants' preference. And this process will really help us refine our items or maybe completely change them based on their feedback, and give us information on item clarity, the appropriateness of the response options we have, what type of examples we should include in the questions, and whether how we should frame the recall time period. So should we ask them to recall, for example, their health state over the past week, over the past 2 weeks, over the past month? And this will really be shaped based on, the questions will be shaped based on what Parkinson's people with Parkinson's tell us. And to do this, we will be using a well-established and accepted probing methodology, which will help facilitate the process and place less burden on our respondent. And to minimize respondent burden, we'll be questioning each person on 3 questions, and we anticipate we'll probably need about 12 to 25 people to really finalize the questionnaire. And this is based on our previous experience with this process, which has worked really, really well in the past. So how might these questions look like? So I wanted to give an example from our MS specific index. And for example, I mean, it might be very different from this, but just to give you an idea, here's a question on walking. And this is based on what people with MS told us. So describe your ability to walk in the past week. Most often, I could walk briskly for recreation or sports. I could walk to accomplish the tasks I need to do during the day. So, and these examples were based on what they gave us: to and from transportation, public building, or within work environment. And our third option, I could walk only a few steps, or I always used a wheelchair. Or here's another example. Fatigue is a very big problem in MS. And this was an area that people with MS nominated as being important. Describe your fatigue in the past week. Most often, I never felt so tired that I had to rest. I felt so tired that I had to rest 1 or more times throughout the day. I felt so tired that I had to rest most of the day. So once we develop our questions, then we will recruit English and French speaking men and women with Parkinson's with different times since diagnosis to value the different questions that are included in our new index. And to do this, we'll be using a secure web-based survey. And we'll be using a standard methodology, which is called Discrete choice experiment, to value the different dimensions in the index. So what is Discrete choice experiment? So this is a widely used method for eliciting patient preferences or values. On this slide here is an example of a discrete choice experiment that compares 2 rehabilitation programs, so 2 rehab programs. So program 1 and program 2. So program 1 is individual therapy. It's 30 minutes per day. It costs $100 per week. It's the same specialist team from admission to discharge, and it's 90% recovery. Then program 2 is group therapy, 2 hours per day, $20 per week, different specialist team involved for each phase, and it involves 80% recovery. Your outcome is 80% recovery. And then the patient would be asked, which rehab program would you choose? Program 1 or program 2? So the response can change. There's no right or wrong answer here, depending on what each respondent might choose a different answer. So this is an example of a discrete choice experiment where respondents are asked to choose between 2 options. So we will use this methodology to develop or to elicit values or preferences for our Parkinson's disease specific index. So our participants will be asked to make a choice between 2 health states, health state A and health state B. Sorry, that's a typo. So this question asks you to make a choice between 2 health states. Please indicate which health state you think is better by placing a tick in the box immediately below. They'll be given this instruction, and they'll be presented with 2 health states. And these health states will really be defined, and this can, of course, this will change depending on what the questions are in our index, but will be defined by the questions in our index. So for example, health state A might be, you have no problems in walking about. You have slight problems with washing or dressing yourself. You have slight problems doing your usual activities. You have moderate pain or discomfort. You're not anxious or depressed. And then we have a description for health state B. You have moderate problems in walking about. You have no problems with washing or dressing yourself. You have moderate problems doing your usual activities. You have severe pain or discomfort, and you're extremely anxious or depressed. So once again, and then which health state do you think is better? A or B, option 1 or 2. So again, this depends on what a respondent will tell us. And they'll be presented with a series of choice sets like this. So our goal is to develop a new index for people with Parkinson's. And really, we'll be generating the domains based on what people with Parkinson's tell us and that are important to their quality of life. We will then develop the questions with a working group, prototype questions, and our group people with Parkinson's will play an important role in this. And then we will elicit, then we'll do interviews, right, to develop these questions during the, and really finalize these questions. And then we'll elicit people's preferences or values for the different questions and using standard methods that we have, well-established methods. And the last part of this process will be to perform some preliminary validation of our new index. So it's important to test the validity of our index before it can be used in practice. And that will be the last and key important piece of our project. And in fact, Dr. Mayo, Nancy Mayo and colleagues at McMaster University, they included the new MS Quality of Life Index in their randomized control trial that tested the effects of a novel exercise program compared to standard guidelines in people with MS. So they had 2 groups. Both got exercise, but one followed the standard guidelines and the other group followed a new individualized exercise program. And what we found was that the new MS index was much more sensitive to change than the generic quality of life indices, which supported its use in clinical practice and research. So we anticipate that a Parkinson's specific index that includes the dimensions that are important to people with Parkinson's and that incorporates their preferences will be sensitive or responsive to therapies in Parkinson's. So in conclusion, we want to develop a new index that will help us better understand how Parkinson's may affect a person's health and well-being. It can be used in clinical trials to evaluate the impact of a treatment, and whether this is medication or rehab, such as physiotherapy, occupational therapy, speech therapy, from the perspective of the patient. And it will also help us to compare the costs and benefits of different treatment approaches in Parkinson's, and help us answer questions like, does this treatment work? And if it works, at what cost? And how does it compare with other treatment options that we have? So when Health Canada or regulatory bodies consider a new therapy for approval, they need information about the value of the new treatment based on the lived experiences of people with Parkinson's. So when making decisions about which treatment should be approved, regulatory bodies look for treatments that are most cost-effective and that have the highest impact on an individual's quality of life. And hopefully, we anticipate that our new index will help with this decision-making process. So that's it for today. Thank you. Thank you for having me today. And I think we have some time for questions.
Thank you, Dr. Kuspinar. Yes, we do have some time for questions. So if anyone has questions, please feel free to type them in the chat box. Or if you have any other comments to share as well, please do. If it's okay, I would like to start us off with our question and answer period. I do have two questions. The first question was, who will mainly be the people who administered this index? Will it be clinicians, or I know you talked about clinical trials as well using the index here. So I was just wondering about that.
Absolutely. That's a great question, Amy. So the index, and it will be short, brief. It should take a couple of minutes to fill out, which is really useful in both research and especially when we have multiple questionnaires or outcome measures, and in a busy clinical setting. So it can really be administered both in a clinical context by a healthcare professional, or let's say when the person's waiting in the waiting room, right? Because it is a patient-reported outcome, so will be filled out by the person themselves, and or it can also be used in clinical trial context. So in both cases, what the aim is, because we will have that one value, it'll be able to give us that one value from 0 to 1. It should be simple for interpretation, where we can see change, whether it's from visit to visit, or you would administer it at the beginning of a treatment, and then at the end of that treatment, to see the impact, whether we saw a change in the positive direction or in the negative direction.
Okay, great. And then the second question I had was, are you still recruiting participants to help develop the new index? And if people want to get involved, how would they be able to do so?
Absolutely. So what I will do is, before we upload these slides, I'll give you my email address, and I'll put them. So we will be advertising this. The study is happening right now, so we will be advertising it across locations. And what we'll do is I'll give my contact information at the end of the slide. And before you upload it, and we would love to, if anyone is interested, it would be great to have you involved. So and they can contact me directly. Maybe they could be part of our working group, and also to fill out some of the surveys, the preference elicitation, and it's multiple phase project. So it would be great. we are definitely looking for participants. So I'll provide my contact information before we upload these slides.
Okay, thank you. So it doesn't look like we have any questions coming in, although if anyone does, please feel free to type them. But I did want to thank you again for taking the time to be here today. I know you have lots going on, so I really appreciate you taking the time to put the presentation together and then also taking the time to speak. So thank you very, very much, Dr. Kuspinar.
Thank you for inviting me and having me, Amy. Thank you. It was a pleasure.